And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Welcome to another episode of the Research Works podcast. We have another wonderful article and guest to introduce to you all today. On the show, we have occupational therapist and researcher extraordinaire, Dr. Jodie Armstrong. Welcome, Jodie.
Welcome.
Thank you so much for having me. I feel very privileged to be here.
Oh, it's so great to have you here. And it's even more impressive that you're here because you too are also on maternity leave. So the juggle between, work and thinking and exceptional grandparents, I can see already is at work here.
Absolutely. Thank you, Mum.
I know all too well about great-grandparents, and I believe that your 6-month-old, Adeline, actually got a mention on one of our earlier episodes of the podcast with Dr. Ros Ward. So it seems as though she has managed to get a gig on the podcast before you did, Jodie.
Yep, she's pretty exceptional.
So for our listeners, Dr. Jodie Armstrong is an occupational therapist who recently completed a PhD on the development and evaluation of a therapeutic playgroup for children with developmental delay. Her trial, known as the Learn, Engage and Play, or LEAP study, was a collaborative research project between Curtin University and the Child Development Service of Western Australia. This project aimed to develop and evaluate a therapeutic playgroup intervention as a new service model for children at risk of developmental delay and disability and their families accessing the child development services. The findings from this study have contributed to our understanding regarding the role playgroups play in facilitating child and parent outcomes for children at risk of developmental delay and disability, and providing a protocol for how to develop and deliver effective playgroups. It was this work that earned Jodie the support of the West Australian Health Translation Network's Early Career Researcher Fellowship.
I love how all these awards and fellowships that you get are really long-winded. They're actually very difficult to say, some of them.
Somehow I always end up saying them.
I know. But you do such a great job of it. And Jodie, I think my sort of connection with you was always through other people, because I think we did our PhDs around the same time. I always heard about this amazing Jodie doing this incredible work, and now we're all finished, and it's great to be on this other side of it and to be able to talk about the work you've done. So really huge congratulations on your work.
Oh, thank you. And I must admit, it is exactly the same for me. I heard all these wonderful things about Dana. So it's so lovely to actually meet Dana.
It is really, really cool that we get to cross paths, and, you know, research life is really quite too small that we all kind of tend to know each other eventually.
Yeah. And a fun little fact for you, Dana, which you might not know, I actually wouldn't have a PhD if it wasn't for Jodie.
Really?
Yeah, Jodie helped me with all of the intervention work for my PhD. So we go way back.
Oh my goodness, that is so great.
Yeah.
I love that story.
Yeah.
Awesome.
So Jodie, we like to normally start our episodes with a little icebreaker question. So we thought that today the question we would ask would be, what was your favourite movie as a child?
Yeah, I think anything Disney I loved, but one that was on repeat was Princess Bride. That was always a really good one. Yeah.
As you wish. Yeah. Such a great one. I think that one's still good to watch even now. I think you can still watch it now and go,
aged well.
Yeah, that's right. I'm pretty sure that's producer Ed's favourite movie as well.
Oh,
he's nodding.
Good thinking, yeah.
Well, my favourite movie, I had a lot. Disney, hands down. I think that's a good general one to say.
Yeah.
The one that I watched on repeat and would sing on repeat, my poor parents, was American Tail. I don't know if you guys remember that one about these mice that would travel across the ocean, and they have this wonderful song where they'd sing under the pale moonlight. Do you guys remember that one?
Maybe you could jog our memory a little bit.
Yeah, I must have that.
I'll sing like the mouse does.
Okay.
Somewhere out there beneath the pale moonlight, someone's thinking of me. And that's all I remember.
On.
Oh, no, we can, I could keep going on, but we'll never go on with the podcast because I could sing that for days.
Dana, I think you need an album as well as a podcast.
Hey, podcast the remix.
Right, next year, 2022, watch this space. I'm joking. Ash, what about you?
Well, I'm just trying to think of all the movies that, so when we were ever homesick from school, Mum used to let us go and rent a VCR from Blockbuster, which wasn't a great incentive to go back to school, but
Yes.
and I always chose the Mighty Ducks. So I'd have to say that would have been the favourite childhood movie.
Quack, quack,
Quack, quack. Yeah,
that's a
I know that one off by heart.
Oh, Coach Bombay. So many things to say about that.
Yeah. Actually, controversial, but I think Mighty Ducks 2 was better than the original, but just putting that out there. So
That's a big call. That's a big call.
Yeah.
I'd probably agree, actually.
maybe we should move on to the science of what we're talking about today, and you
That's
could
right. We're here on the
help us
Research
with
Weeks podcast.
No, I'm enjoying this singing and
Yeah.
reminiscing.
You could give us a summary of what we're talking about today,
Sure.
Dana.
So let's go through the PICO format. So the population involved 71 children with developmental delay and a mean age of 28.8 months, so a standard deviation of 5.4 months, of which 78.9% were male. There were two groups in this randomised controlled trial, an intervention group and a control or treatment as usual group. Now, children in intervention group received the LEAP playgroup and treatment as usual. So the LEAP sessions ran for 2 hours once a week for 8 weeks at a community centre, with each group consisting of a maximum of 8 families at any one time, and was facilitated by 2 allied health clinicians providing a transdisciplinary approach. Now, the outcome measures in this study include the Parenting Stress Index, the tool to measure parenting self-efficacy, goal achievement using the Canadian Occupational Performance Measure and the Goal Attainment Scale, Family Support Scale, and the Medical Outcomes Study Short Form Health Survey, as well as the MacArthur Bates Communicative Developmental Inventories, Words and Sentences. Though this first randomised controlled trial to evaluate a therapeutic playgroup for children with developmental delay did not demonstrate that LEAP playgroup significantly reduced parent stress over treatment as usual, it did indicate that LEAP contributed to improved outcomes in family support and goal achievement for children with developmental delay and their families when compared to treatment as usual only within a community early intervention service. This means that LEAP, in addition to usual care, may support improved outcomes for children and families.
Thank you so much for that, Dana. And Jodie, I think we're all quite familiar now with randomised control trials and how they work and why we would use them to try and answer our questions. But we always acknowledge that it's a huge feat to actually complete one. So congratulations on that. In the instance of your particular study, given the age of the participants you were working with, obviously maturation is an important factor to control for or consider, within the context of your results. So how did you find the process of conducting an RCT within a community environment and the existing clinical service that these children were a part of?
Yeah, and I think it might be worthwhile giving a little bit of context as to what the clinical setting was.
Yeah,
before I
absolutely.
launch into my response. So the Child Development Services is a publicly funded early intervention service that provides allied health and medical services for children with developmental delay and their families across the Perth metropolitan area. And we see over 20,000 children per year.
Wow.
Yeah, so it's quite a big service. And I felt very lucky to embed it within the RCT. And I think the question that you asked is really important because we talk a lot about translational research, don't we?
Yeah.
And embedding clinical trials into clinical settings.
Absolutely.
But the reality of doing it can be multifactorial and requires commitment across both the research sector and the health service sector. So I think there was kind of 3 key things that we really had to, from my perspective, help the success of our trial. So firstly, we had a really strong collaborative research partnership. So I was a PhD student, but my research team consisted of 2 research academics who were fabulous and always kept in mind the research rigour and what we had to do from
so important.
a publication base. And then we had amazing clinical managers as research supervisors as well. So we had the director, the medical director and senior portfolio officer. So they always kept in mind the clinical needs of the service and also the practicalities, things like workforce cohort needs, where we wanted to really target our playgroup. And I can't speak more highly of the research team and the commitment across the two, the health service and the research institute. So I think whenever we're looking at doing this, we really have to think about our collaborative research partnership. So we talk about it, don't we, a lot? But I felt very privileged to have the research team that I had. Secondly, it was a consumer-driven RCT, so I wouldn't have even started my PhD if we hadn't. I've done some earlier work whereby our parents and our staff said a playgroup might be a really good way of meeting information and social needs early. And then it was the health service and then partnered. So having a consumer-driven study really helped. And this was actually the 5th study of a 6-study process. So the first 4 studies are really about looking at what is a playgroup, what are our clinical cohorts, and then the feasibility study to kind of iron out some of the challenges of the logistics of RCT before we even got there. So that really helped. And then my 3rd thing, and I promise I'll wrap up this question really quickly. And I don't think this is necessary, but I personally had a clinical experience working in the service for 6 years prior to having doing the PhD, and you don't need that, but I think that helped me understand what the clinical cohort was, even things like the logistics of where we're going to run playgroups, so having a good idea of venue and facilities. Can we do it within the service, or should we look at community centres to do that? So, you don't have to have that, but it's really good to have take the time to get to know the service and be respectful, because as you said, that they're running a service, they're busy, they're doing really good work. That's right. So it's really looking at kind of how we can partner in a way that benefits both.
Absolutely. And I think, we talk a lot about translational research, as you said, and I think it's really important to understand that, often RCTs will happen in what we would call a bit of a research vacuum, where you control everything so tightly in order to pinpoint, the exact effect that the intervention that you're trying to prove is having. But you've talked so beautifully about all of the key ingredients that you need to embed an RCT into a service to make sure that the outcomes that you are generating are actually applicable to the clinical service that you're working in. I think that's so important and probably, almost a new wave of research, new direction that we're heading in.
I love how you have done this. It is not easy to embed research in existing clinical practice. And I love how you've highlighted all the essential partners to make this happen. And I think, when you think back to Mitch Adams' podcast a little while back, and he talks about the logistics of running something, there is so much involved, and it just shows it's not done as one person. There's a team.
Absolutely.
And if it's a team, then, again, we do these things together. It might need someone to drive it. And as a PhD student, you're going to be the one driving it. But knowing what is needed, what's essential for the service, and trying to, really find solutions. At the end of the day, I think research isn't just to kind of go, we found these outcomes. It's actually a great process to understand the service and the mechanisms that make it work. And you streamline things along the way, and somehow knowledge translation just happens because you are doing it in that way.
Yeah.
So it's really cool, Jodie. Well done.
Yeah. Oh, thank you. And I must admit, it was a huge it was a huge learning curve for me, but there's no way I could have done it without the support of the research team and a real commitment from both sides. So I feel very privileged to have been the PhD student doing this. Lots of cake and lots of rocky road to get us through all those research meetings. But they were a fabulous research team, so I can't speak more highly
about
of
your
them.
Meetings. There was always cake. Yeah. I did hear that. It's actually quite well known. I might just put that out there. I have heard about it.
It does help getting everyone to the meeting every time.
It does. Very, very wise. Okay, so now just a bit of background into your research. I know we're really focusing on this one main article, but I really want to sort of go into some of the terminology. So we've got that, a little bit clearer before we get into the results. So first up, developmental delay. We often hear that as quite a broad term, obviously, to describe how children might present. So just for clarity, is developmental delay a diagnosis, or is it more of a descriptor? How do we use that?
Yeah, so developmental delay delay is not a diagnosis when we're talking about DSM-5 diagnoses. It is more a descriptor of delay, but I don't want that to be confused with global developmental delay.
Yes.
So that is a diagnosis, as we know, under the DSM-5. So when we're talking about development delay in this area, it's more children that are showing that they are delayed. We looked at we used the Mullins Early Scales of Learning and also ASQ to show that there was a delay there, but it's not a diagnosis under the DSM-5.
Yeah, sure. Okay, so what do we often see in children that present with developmental delay? And I mean, obviously here you already talk about the age groups. We're talking quite young already, but what are some of the things that, might drive a referral, for example?
It can vary so substantially depending on the age, the severity of the delay, even the type of delay. So is it a single delay? Is it just my child's not speaking and something very obvious, or is it multiple? For these children, the cohort had to have a delay in communication and at least one other area. Right. So when you're thinking about 18-month-old child, usually it's a communication that parents may notice first. Younger, I'm sure it's, if they're not kind of crawling or walking, but particularly this age, it's my child's not speaking yet. It's not looking the same. So that's usually for this cohort of our study, and that was kind of the first thing that parents may notice.
Yeah, sure. Yeah. Okay, and I can imagine now, like we're hearing a lot about just the increasing volume of referrals that a lot of service providers are receiving. How can we use playgroups as an alternative model to support families who have identified, this possible developmental delay?
Yeah, so I think that increasing demand, I'm not sure if you're aware, the recent statistics showing 1 in 5 children are entering school with a delay in at least one or more areas.
Wow, okay.
So that's, and you combine that with the increase in population of young children, the demand on early intervention service nationwide is definitely increasing. So yes, I said earlier it was a consumer-driven study. So it was actually when we interviewed our parents and staff many years ago before I started my PhD, they actually said playgroups might be a really effective way of getting information early, and also really importantly, an opportunity to meet other families going through the same situation. Because it can be really isolating for families when they're looking at all these other children.
Of course.
Developing and their child not developing. They want to connect with someone else going through that. So playgroup was seen as an opportunity of seeing many children at the same time and a really kind of hopefully effective way of seeing children.
Yeah, sure. And in your paper you outline 3 different types of playgroups, which I know you defined more in early work of your PhD, but just in brief, you talked about community, supported and therapeutic playgroups. Can you just in brief talk about, what the differences of them are?
Yeah, absolutely. So most listeners may be aware of the community playgroups. So these are the universal parent-led playgroups. So hopefully there's one in your community around. And then we move to a more supported playgroups. They're usually led by a facilitator. They might be some activities organised. It's usually catered to a certain a certain group of families. So it might be multicultural families and might be parents of children with autism.
Sure.
And then therapeutic playgroups. And these are definitions that we really developed as part of the PhD because one of the issues with playgroup research is defining the differences between these playgroups. But our definition of a therapeutic playgroup is that it's conducted by an allied health or a qualified professional. There's intervention that's embedded into the playgroup and that it's really catered to a specific diagnostic group. So that's...
It's great to be able to identify the difference because I think we are all quite aware of playgroup. And in your paper, you do talk about how, as Australians, it's something that we were probably quite used to, and I didn't quite realise it was probably something that we're used to seeing and in our community. So I think that's really worthwhile reflecting on. And just the final thing from me in this background sort of understanding of things is I understand with developmental delay because it's not a diagnosis. It doesn't mean that children are able to access NDIS funding yet or anything along those lines. So I gather something like a playgroup is much more economically viable. Is there much work done on that?
Yeah, I think although for our study it was for children with developmental delay, I actually think the therapeutic playgroup is a model that could be really embraced in the NDIS area for children with developmental disability diagnoses because I see it as one, it's an effective way of seeing a large number of children. Group is always more cost effective and a good way of seeing more children. But in some way I think it's a really beneficial way of providing evidence-based care within an environment whereby it really enhances the peer support between parents. And I can't emphasise that enough, is really important and I think unique in the playgroup sector. And it also provides natural learning opportunities. It aims to build capacity and it also focuses on linking parents with their community as well. So I think it's a real win in the disability sector and I hope it's seen more and more, this playgroup model, because, it achieves hopefully good outcomes for children and families. So, and also a win from a service in regards to being able to see a higher number of children to meet that increasing demand.
Yeah,
that's great.
Jodie, I'd love for us to be able to talk a little bit more about the specifics of the intervention, if we could, for a minute. So LEAP stands for, as we said earlier, Learn, Engage and Play. And this was a therapeutic playgroup for children with developmental delay. Could you just talk to us a bit about what LEAP looked like, what the key ingredients of LEAP were as such?
Yeah, of course. I suppose the intervention characterized what it looked like from a day-to-day. It ran for 2 hours, once a week for 8 weeks. We had about 8 families that were involved, 2 allied health clinicians that worked in a transdisciplinary approach. That was really important and also implemented coaching. I worked within a coaching framework. Right. In regards to the key elements, one was the facilitated characteristics. So I wanted them that they worked in a family-centred way and coaching and transdisciplinary. Then from the participant perspective, that was really important in that they had kind of similar challenges so that we could really enhance that peer support. And in regards to the structure of the playgroup, we wanted to make it feel and look like a typical community playgroup. So that you had some indoor activity, then you had the snack time and tea, coffee time, and then the outdoor activity. And also what was really important about the tea and coffee time, it sounds silly, like have a tea and coffee, but that was a really important time whereby we could provide opportunity for parents to connect with other parents. And so that's where it might have looked slightly different to a therapeutic group, and that was a really key therapeutic ingredient was actually that tea coffee time.
And facilitating that parent connection and hopefully peer support between the parents. Was that kind of the aim of that?
Absolutely. And one other thing that I didn't mention before is each week had a different key message. So it was kind of importance of play. Then we moved to kind of using children's interest in play. So the idea was there was a broad key message that was discussed. And then also the indoor and outdoor, because it's unstructured, really allows for that relationship building between the therapist and the parent as well, because you can go and individually talk through things and coach, and then the building of that peer support and facilitating that in that snack time that you hoped would then transfer to indoor and outdoor play.
Oh, it's a beautiful model.
Yeah, you can't underestimate the importance of just thinking about those opportunities for parents to connect, isn't it? And I guess that leads really nicely into the outcome measures that you picked. And I love that your outcome measures that you did use does reflect like the range of things that you wanted to look at. So you looked at parent stress, parent self-efficacy, family support, quality of life, communication, and goal achievement. So just practically, can you talk us through when you did the assessments and how long did these assessments take, just the practicalities of that?
Yeah, the battery of assessment, the initial always took a little bit longer because if you're familiar with the goal measures that we use was the Canadian Occupational Performance Measure and the GAS goal attainment scale. So that takes a little bit longer to actually set the goals and measure that. So that usually took about an hour and a half for that initial battery of assessments, and then the follow-up would take around about an hour. So practicality, if I was to recommend things in practice, I think the goal attainment scale is really important, and the COPM, and that comes up again and again in the research around the importance. And it's clinically meaningful as well, and you hope your intervention reflects those goals, and they're a little bit quicker, and as you become quicker as a therapist doing it, that time reduces quite substantially. And also I think something like a family support scale, that was really good to kind of see where those strengths and areas for further growth could happen.
Sure. And you had 3 assessment time points, didn't you? Can you just talk us through what they were?
Yes. We had one at baseline and then one immediately after the group. So one kind of within 2 weeks of the final playgroup session for your control and your experimental, and then one again at 20 weeks.
Great.
Yes.
Yeah, no, that's fantastic. So it's great that you had that follow-up as well. I think sometimes it's that period post-treatment to follow-up that we're really interested in, because sometimes I think we lay the groundwork. So I think it's great that you had those measures.
Yeah. And that's real life, isn't it? Like, that's talking about, application in the real world context, that period of time is really important to see what
happens when we have to step out and what that looks like.
Yeah.
So Jodie, jumping into your results, firstly, I'm really interested in attendance. Families are really busy and they all have, lots of different things going on. How did you find the attendance of your participants to your trial?
Yeah, attendance was really good.
Yeah, great.
I suppose clinically I always expected, sometimes in groups you expect kind of a high level of dropout.
Yeah.
So what we wanted was parents to attend at least 6 out of 8 sessions. So that was kind of the minimum dosage. And we got that number from a scoping review we did in earlier work in regards to the minimum for hopefully therapeutic gain. So we did 8 thinking children would be sick, things pop up, but no, most of it was the average attendance was 7 out of 8 sessions.
Oh, fantastic.
And I think also what helped a lot was we encouraged siblings to come along.
Yeah.
Because I know a lot of groups there's no siblings involved, or aunts and uncles are not encouraged, but being the true essence of a playgroup was that, we allowed older or younger siblings to come, and sometimes grandma would come as well, or they'll, mum or dad would arrive. So that I think really helped attendance.
Yeah, definitely, reducing some of those barriers to being able to come along for some families. Yeah. And I see from your results that your primary hypothesis that LEAP would reduce parent stress more than kind of treatment as usual wasn't actually supported. Was that something that you were surprised by?
Let's be honest, Ash, you really want to show significance in every single area.
Yes.
It's always a little bit disappointing. But no, my response is kind of yes and no. So the feasibility study was done before, and that was only done with 8 participants, so it was very small. But we actually found kind of similar findings across that and the RCT. So I think 2 things could have contributed to it. One, parent stress was actually much lower than we expected.
Okay.
So when we compared that baseline of parenting stress, it wasn't in that kind of clinically significant range at all. So when we compared it to other studies that had done used the same outcome measure with the same population, ours again was much lower. So I'm not sure if that created somewhat of a ceiling effect or not. I think, you're presumptuous to say that it was that, but that might have contributed to the fact that actually it was much lower than we anticipated, so then the drop was somewhat different. And the second one was the study was underpowered.
Right.
So we didn't quite, we were hoping to get to around 86, but just due to time constraints and the logistical challenges, we couldn't continue to do more rounds. So again, we're also not sure if that contributed to the finding. But what I do like about just the overall findings was, despite them being quite low to start with, they dropped in both groups. So I think clinically what's nice to take away from that is parenting stress will reduce, or shown to reduce once parents started to see therapists and started some services. So I think that's kind of nice for all of us as clinicians to know, is that providing services generally reduce our parenting stress.
Yeah, that's a really great point. And you did find significant group differences for family support at that 12-week point after the intervention, which was a really interesting and exciting result. So what features of the intervention do you think led to that change in your intervention group?
Yeah, I think personally this was probably the one that I got most excited by. Which, might sound a bit silly. But I think this really speaks to the emphasis on increasing family support and peer support within play groups. And I think, I suppose me speaking from a clinical perspective, one of the biggest difference between therapeutic play groups and therapeutic groups is that emphasis on that peer support and the encouragement and the facilitation. I think back to my usual OT groups that I might have run, and parents might have chatted briefly in the waiting room, and there might have been a brief opportunity, but because this was so integral to the framework of actually increasing that those connections, I think that's what reflects it. And following the RCT, we actually did interviews as well with our participants, and there was one quote that always sticks out was, this is the first place I didn't feel alone.
Wow.
I felt my child was accepted.
Yeah.
So that, for me, felt that we actually were true to the framework of the intervention.
Yeah.
I think the reason it dropped off and it wasn't sustained was just the logistics of the RCT. We had to recruit families from quite a wide geographical area.
Right.
So, some parents were driving 1 hour to get to Playgroup. So something that they said really put up barriers to continuing that was just the travel and citing that as a real challenge. So it wasn't really run in the community as we would have liked. So the family kind of support might have dropped off and not being able to maintain those connections.
Yeah.
I guess it's just those environmental barriers, we know they contribute to it. But I think what's lovely about both those results, even though it's always a bit disappointing when your original hypothesis wasn't supported, but it just shows the specificity, though, the fact that both groups went down in terms of parent stress, but family support had improved. That does show the specificity. And the other one that got me really excited was goal achievement. So you reported significant differences between the groups post-treatment and the follow-up. And this really does, again, speak to the fact that the group addressed, child and family priorities. So specificity again. Do you think there's any other sort of factors that may have contributed to that? Or did you have any other thoughts on that?
Yeah, I think the outcome measures themselves and the sensitivity of the outcome measures. So the COP and the GAS is what we used. Yeah. And I said briefly before, they're used quite commonly in intervention research, and actually we're doing a systematic review to try to identify the best outcomes for community practice. And not surprising, particularly the gas comes up time and time again because it is actually really sensitive to change. So I think actually finding measures that did actually capture that change probably helped with that. And then secondly, I think it probably ties into the intervention itself, but I also think it comes down a lot to the therapists as well. So we had some really fabulous therapists running our Playgroup. They were really skilled in that transdisciplinary and that coaching framework. So the intervention itself and inclusive of our amazing therapists that were there and supporting each other and supporting the parents.
Look, I remember when transdisciplinary was sort of first introduced as a thought, and I was quite a young therapist at the time, so I didn't quite understand the importance of it, because here you are having just graduated and you're, I'm a physio, this is what I do. And then I remember just, it was quite siloed to start off with, it was very much the multidisciplinary. We were all there. It was, as Matthew Haddon, who's been on the podcast before, talked about, it's like a salad. You can see all the individual components. But the minute you go into making like a quiche, everything's sort of there and intertwined with each other. It still tastes real good. It's one nice, delicious quiche. You can still identify the individual components because that's the strength of your discipline. But really, to everyone else, you can't really tell where the eggy bit meets the cream, and
it's seamless.
Put it back to food again.
Yes, always.
But I love how you've just shown that the transdisciplinary model can be really effective when you're looking at these sort of wide-ranging goals that are child and parent priorities. And I think that's actually so wonderful and a great encouragement to us.
Yeah, I do think it takes quite skilled therapists to do it. Yeah.
Absolutely.
Yeah, the idea of doing it as a new grad can be challenging because you're trying to work out what your role is. And these are really experienced therapists that had kind of worked in lots of different models. So I think, if you got the experienced therapist transdisciplinary, and for the parents, they actually didn't know what the professions were of some of them. They didn't know whether it was a speechy or OT or physio. What they got was consistent information that supported them. So
and that's a great signal.
Yeah. And coming back to that goal setting exercise as well, that becomes really crucial in that as well, because everyone's on the same page and aligned to, what the goals of the family and the child are. So, a really key ingredient there. So, Jodie, from beginning to end, this trial was 7 months. Probably felt like much longer than that. But, in the life of a child, as a therapist and now as a mum, you know and understand there's a considerable amount of time, that so much can happen in that 7 months. And you said in the discussion that, for communication developmentally that, you would expect some improvements in communication skills over that period of time anyway, regardless of intervention. And so I suppose this can be really quite reassuring for families and service providers. But just wondered if you had a bit of a comment about, maturation and how that plays into the results that you might have found.
Yeah, I think that's why it's so important to have a control group, isn't it?
Yeah.
Absolutely.
Because you can always say, oh, the therapy was fabulous and we showed an improvement, but if it doesn't have a significant difference to a control group, then it's got nothing to do with your therapy.
Yeah.
So I think that's where, RCT is really important, particularly when you're trialling new interventions to see what it's like. I think also it's a big learning curve from us clinically as well, that we don't want to be complacent in knowing that, the kids will improve, and sometimes you can think this is really working my therapy. But if we're not really implementing evidence-based practice and if we're not constantly reviewing our practice and doing more research on what we're currently doing, we can potentially become a little bit complacent in not relying on these maturation effects, but when you're looking at outcomes pre and post, it might not be to do with your daily practice. So I think it's it's kind of something that we have to be aware of clinically and from a research perspective, that we want to constantly be implementing evidence-based practice.
Yeah. And studies like yours really help to highlight what impact a new intervention might have beyond what you'd expect in terms of maturation, particularly at this age, which is, there's so many changes happening developmentally.
Correct.
So it's can be really hard to unpack what is developmental and what is
and that
attributed
makes it
to therapy.
Even more clever in the fact that, again, I've heard a lot and I've seen people sort of saying things like going, well, at this age, it's so hard to do research in this area. 100% agree. And
For lots of reasons.
That's right. You need to have a lot of things in place. But I think the fact that, you had treatment as usual and, that's, you're not saying that you can't do anything. They are still doing their usual anyway, but you're adding this on top to see whether that would actually make a difference as well. So it's not like you're just withholding. So in terms of the ethics of it, you're still very, very thoughtful about that. So we're still thinking about children. Like research isn't cold. It isn't this thing where you go, well, we're just going to look at this and it's about people and in a real life context. So I think this is why there's so much more strength in this. So I think with regards to like how you would implement that or how clinicians could take this and go, well, how can I run my own play group from a therapeutic perspective? What would be sort of some of the things you'd say that would support optimum outcomes?
Yeah, I think, so as I said, I think therapeutic playgroups can be used from lots of different diagnostic groups and population groups. I think as I spoke about before, the peer support is really important. And one key thing about peer support is a shared experience, so that shared lived experience, so that I understand what you're going through, you understand what I'm going through. So thinking about the cohorts of clients that you're working with. So I think it's really important to think about having kind of consistent cohorts in your play group. So whether it's a play group for children with like autism, or whether it's a global developmental delay, or cerebral palsy, that there's some shared experience in that journey, so that they can really relate to each other and support each other and get ideas for resources and community groups and also from an emotional perspective to be able to support themselves. And then leading into that is for the group itself to really prioritise and allow parents to actually have opportunities to talk to each other.
That's wonderful.
So that snack time was something that was, even from our fidelity, when we were reviewing our fidelity, if the therapist sat and spoke to the parents the whole snack time, that was something that, no, you actually have to see if you can, remove yourself, so you allow that discussion as well. And really place importance of that. The peer support is really important. And then from an intervention perspective, I think a minimum of 8 weeks worked really well. So trying to get that 6 weeks, that was the one thing that actually parents were most upset about when we got qualitative feedback. They wanted to keep going and going and going, which is really lovely. But also you've got to realise, I suppose, the cost perspective. But then that also speaks in regards to the importance of linking them in with other play groups. We actually did have some of our participants say that they had met a few mums in their play group and they felt really comfortable to then, as a group of 3, go into their local community play group. So
that's wonderful.
kind of think about how can we actually, the longevity of this peer relationship and the support in linking them too. And then I think, so you want really skilled therapists, as we're talking about, that could actually work within, coaching. And we talk about coaching framework, but it requires a lot of skill, doesn't it, in regards to learning those practices. So really skilled therapists that work in a family-centred way, and that coaching. And lastly, the actually intervention setting itself. So this is something that we're really quite specific about, is actually finding a room that had indoor and outdoor facilities.
Yeah.
And also, as we said, the access to tea and coffee,
Yeah.
which sounds
Yeah.
silly, but whether it's
It's actually so important.
yeah. So it sounds silly reinforcing this, but I think
Yeah.
that really was a key component to our playgroups. So having a range of indoor and outdoor activities, so parents and children can get exposed to quite a range of different activities they might not have tried at home.
Yeah.
And then it's very much easier for parents to actually engage with their child and play if they're finding something that the child's actually enjoying.
That's cool. Maybe a few bickies,
Yeah.
Tim Tams.
Yeah.
Love a bicky and a coffee. Yeah. Well, Jodie, I think you've given all our listeners some really great recommendations to start thinking about if this is something that they want to implement into their practice, which is fantastic. And I always like to finish off with what's probably quite a big question for you, given all that we've talked about today. But, given what your journey has been within this research project, what would be your recommendations for future work? Where to from here?
From, I suppose, a research perspective, there's not a lot of research out there around playgroups. So I hope that this can create a little bit of foundation or at least one study that other researchers can continue to build on and look at playgroups for different diagnosis groups, so we can really kind of see how we can use this in the best way to support our children and families. I think that's kind of really important. And then I suppose for the future of LEAP, we are just in the process of packaging it all up into a manual. So it wasn't a manual, but I suppose packaging all the key resources such as the kind of cue cards and handouts and facilitator scripts with a marketing company, which we've been very lucky to be able to engage using the WHTN. So I've used the acronym when you had to say the whole big one.
That's okay.
So the fellowship, and the co-match funding with Curtin. So we engaged marketing companies to really kind of package that up. So that's quite exciting. And also made me realise how uncreative I was. It looks much more beautiful than I could have. So that's kind of what we're looking at. Kind of the future of LEAP. Is it something that we can really offer to clinical practice for clinical practice, but also for further research for it to be tested potentially more rigorously. So that's a future of LEAP as such. Is that kind of it's almost ready to.
Oh, that's so exciting, and another step towards a sustainable, ongoing model for these families, which is really exciting.
Yeah, well, congratulations on all of that. Look, this is the really nice segue now into the next segment where we can summarise all of this so we can talk about it to every single person that we come across, really. So now we'll introduce you to the 60-second pitch to the everyday man, Ed. As you know, Ed is our producer. He doesn't have a background in child health. He does listen in on all of our conversations. And I see him nodding from time to time. And I think he does agree with a lot of what we're saying. He's taking it all in.
He's learning.
He really, really is.
He's like a sponge.
He is. Now, Jodie, this is the opportunity in 60 seconds or so to summarise your research and your work in this area to someone who doesn't have a background in child health. So take it away.
Right, Ed, let's see how we go. Okay, when parents were first referred to our service, they said what they wanted was early information and access to other families going through the same situation. So an idea of a therapeutic playgroup was suggested by both families and our staff as a way of meeting this need. So this study looked at really evaluating the playgroup that we developed to see if it was more effective than what they would usually be getting through our service. And what we found was that families that attended the playgroup, their children seemed to have better outcomes in the short term and the longer term than those that did not attend the playgroup, and parents that attended had better social support or had an increase in social support immediately following the playgroup than those that didn't. So we hope this starts a wild world of research around therapeutic playgroups.
That was a beautiful
So
summary.
good.
Wow.
Concise. It had everything in it. That was really, really good. Yeah, well done. You've done this before, I think. All right, Ed, over to you for a question.
So I've been listening quite intently. And I think the whole playgroup thing and the allied health professionals sounds brilliant. And I tend to ask the questions about, the everyday kind of guy questions. And sometimes I put on the parental cap. And you mentioned, obviously in evidence-based practice, you need skilled therapists to pull this kind of an intervention or a program off. If I'm a parent, how would I be able to identify whether my therapist would have the necessary skill level. Like, is there something like a tick box? Is there like recommended therapists or places that would be able to pull this kind of thing off, or is it something that we work together with our local therapist? Or
Whoa,
I think that's a good question.
That's a great question.
sorry, is that too long-winded?
No.
It's a perler. You've done very well. Yeah, I think I probably should say that it's not that it's you have to be the most skilled therapist to pull this off. I think you just have to be reflective and work with parents. So I actually think that you as a parent, you're the most important person, you and your child. So you want a therapist that, one, you actually get on well with. So relationally, you find that they respect you and you respect them and you actually like them. I think that's really important. So those relational skills of a therapist.
Sure.
And that they respond to your concerns. So they're actually asking you about what your concerns are and what your goals are, and if they're able to give you strategies and you're seeing improvements with your child and they're able to answer your questions and support you to feel more confident in actually helping your child to achieve those goals. I think they're the most key things, and that's what we ask parents about is, do you, one, get on with them, and two, do you actually think that they're asking you what you want to do and what you want to achieve, and they're actually supporting you to get there.
So more relational than technical.
I think it's a balance. Yeah. And actually the research shows it has to be a balance. There's a relational and actually the technical and having the answers to your questions and supporting you with all those different techniques and tricks and coming up with suggestions on how to support your child in collaboration with you.
Okay.
Is that a long-winded answer?
No.
That was really good. Well
Yeah,
done,
I
Ed.
know.
That's a really good question. Got me
Thank
thinking
you.
there
Keeping
as well.
that bar high.
Yeah. I'm like sweating here.
No, I think you did a brilliant job.
Yeah.
Jodie, thank you so much for joining us on the podcast
thank you so much
today.
for having me.
We've loved chatting to you about it. Remember for everyone, if you want to look at the run sheet notes for this, head over to our website, researchworks.net. And of course, if you want to record this as part of your CPD requirements, head over to the website as well. There's a form there that you can fill out so we can help you keep a record. But for now, we say goodbye once again.
Yeah.
And
Thanks so much for having me.
Thanks, Jodie. We really enjoyed having you on today.
Oh, hopefully I was coherent and made sense. Thank you so much.
Thank you so much. And talk to you guys all again next week. Bye.
Thanks a lot.
Bye.